exam begins with inspection. So I'm inspecting my patients for the eye exam, their eyelids, to make sure that there is not a sign of infection or sty or hordeolum, there isn't any discharge, that her eyelashes are intact. I'm also looking at her sclera, which is the white portion, her irises, her pupils, to make sure that they're approximately the same size, or if there is evidence of anisocoria, and to make sure that her forward gaze, just at me, appears about level and appears that there's no evidence of lateral gazes or amblyopia, strabismus. So that's just my general impression. Then I'm going to take my patient, I'm going to tell my patient, I'm going to put my thumbs on underneath your eyes, I'm going to pull down your eyelids to look at her conjunctiva. So I'm going to pull down your eyelids. So then I look and I see the pinkish portions underneath her eyes. Hers look very healthy, but you're looking for different colors. You want to see a nice pink color, almost reddish color, but you're looking for evidence of jaundice or yellow discoloration, or if there's pallor, they appear less pink or almost white. That means that she could have anemia. For infections like conjunctivitis, it'll be very, very red, swollen, and there'll be some discharge, and the sclera may even be injected or look red. And so that's the general inspection that we do there. So then after that, we test our visual acuity. Does anybody have their Snellen chart with them? So we practiced that yesterday in class. We won't go over that too terribly much. Thank you. But remember that this chart's approximately 7 inches, and it should be approximately 14 inches for your patient. So really, if you take it on their forehead and you flip it out, then that's about where 14 inches should be. That's testing near vision, so you have your patient loosely cover your right eye and read the lowest line down that you can.
5, 6.
Wow. And then loosely cover your left eye and read backwards the lowest line that you can.
6, 5.
Okay. So, and then you, with both eyes open, read the lowest line that you can.
5, 6.
Okay, so my patient has approximately 2,800 near vision. And then this is uncorrected. You guys saw she had glasses on, so at this point I would ask her to put her glasses on and then read the lowest line that she can.
6, 8, 3, 2, 7, 9.
Wow, see that's much better. 2025 corrected her too. So then I would document that near vision, left eye, right eye, corrected and uncorrected. Document it that way. And then we've got set up here our far vision chart back there. And this green tile here is about 20 feet. So you would do the same thing. Left eye, right eye, both eyes, corrected, uncorrected, and document that as far vision. Now, you're going to do this mainly whenever your patient comes in with a vision complaint. This is not typically, they come in with shortness of breath. We're not going to take time to do this one. So that's visual acuity.
However, if they come in with a visual complaint, don't forget to check their vision. I mean, somebody who's had an eye injury or who has eye pain or who has eye discharge or whatever, you can't assess that problem without assessing their vision. And I've seen it a million times. If you refer to an ophthalmologist without checking vision, you're going to get belittled, to say the least. Yelled at.
So next we're testing cranial nerve 3, which is the direct and the consensual pupillary light reflex. So I'll ask my patient to take the glasses off once again. And if you guys want to come in a little closer with Mackenzie's eyes, you'll be able to see pretty easily because she has light colored eyes. So you have your patient look straight forward, and actually, can somebody twist those blinds closed because she's looking directly into light and that's going to cause her pupils to constrict. Thank you. Okay, so look straight forward. And you notice now her eyes are fairly dilated. So when you're checking direct means you're looking into the eye directly. And so you're going to watch this pupil constrict. See? And then for the consensual, I'm going to shine into the right eye, but I'm observing, her left eye, but I'm observing her right eye. And it constricts as well. So that's direct and consensual. You do the same thing on this eye. So this first I'm watching her right eye for direct. And then I'm watching her left eye for consensual. And you notice how I gave her a few seconds for her eyes to dilate once again so that you can actually tell the difference. Don't, do this and this. Because I probably do patients too. So that's direct and that's consensual. Alright, so next I'm going to test for accommodation. And this is where you're going to observe her pupils. And they should slightly constrict whenever she goes from looking at something far away to looking at something close. And you're also going to notice there's going to be, her eyes will pull in just a little bit to focus. So look at the blinds back there. And now look at my finger. And you'll see that her pupils constricted slightly. It's not a big change, but you have to observe very carefully for that. So that test is for accommodation. Extraocular motions. So I'll have my patient look at my fingers, and only at my fingers, and follow them as I move them. And that's when we do the H sign. And remember, we do lateral gaze. This is a lot of times where we can see things like nystagmus. And you may see a few normal beats of nystagmus. Mackenzie doesn't appear to have that, but sometimes it can be normal. But if it's sustained, and then you also, do midline vision to check the medial muscles. But if it's sustained, once up here, the eyes will beat, 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 beat. I'll see, I meant to look on YouTube to see if I could find a video of nystagmus, but I'll see.
Found a good one on YouTube.
Did you?
I just Googled.
Okay, so that can mean different things. Cerebellar injury, sometimes labyrinthitis can do it. Certain drug toxicities can induce nystagmus.
Vertigo.
So it's something that something that you look for with that. And so that tests her extraocular muscles, the EOMs. Next, we do visual fields by confrontation. And so again, this is a rudimentary test. And so you attempt to simulate it on yourself. By closing one eye, and you close the same eye as your patient. So I'll ask my patient to close this eye, and I'll close this eye. So we both have these eyes closed. You can do that, or you can have her cover, which might be easier for your patient. Either one's fine. That's a cute ring. So, all right. So what I'm going to do is I'm going to test all 4 quadrants: superior temporal, superior nasal, inferior temporal, inferior nasal, all 4 quadrants of her vision. You can either do the counting the fingers test like we did in class yesterday, or you can do, in your book has an example of a wiggling finger test. And so you tell your patient, point with your finger whenever you point at my fingers whenever you see them. So I'm going to close my eye, and I'm going to wiggle my fingers in. Okay, so she points down there. Okay. Okay. And that was approximately the same time that I could see them as well. All right. And so then I'm going to test the opposite visual fields. See, and I didn't even see that then, so hers is better than mine. And then we'll switch eyes. So cover that eye, and I'm going to close this eye, and then point at my fingers. Look straight at my face, and point at my fingers when you see them. See them both, and then the opposite side. Okay. And it's about the same time that I saw it. So, roughly her visual fields are intact. So an abnormal one was if you're sitting here and you've got your eyes closed and you're seeing the wiggling fingers and they're not pointing at all. That would be the abnormal.
So you tell them to tell you whenever they can see both, not just one.
Point at the ones that you see first, because technically you're probably going to see one before you see the other. So just they'll point whenever they see them.
And if there's a question, you can back off and do each one separately.
Gotcha.
Mm-hmm. Okay. All right, so then next we get to the photoscopic examination. Take your time with this. So we had problems with some scopes in the previous lab. So if you notice some problems, for instance, if your light bulb won't dim, which this one does a little but not a lot.
Most of them don't a lot.
Yeah.
Dims it all, it's better than some of them.
Yeah.
So we have a list. If your light doesn't dim at all, I need to know. I think it's an issue of the bulb, and I'll get you a replacement. But we also noticed that some people didn't have a clear circle.
This one's good. So see how this circle in my hand is round all the way around? Some people, it looked like an eclipse, like there was a dent in the very top of it. So make sure that yours doesn't do that.
And if so, I have a list and you need to let me know. And we'll be in touch with Brad.
So put the light on the dimmest setting that you can. And then you can remember how in the first lab we talked about how, see, there's different sizes of light. This is a small one. It's typically better for a non-dilated eye, and then you can choose larger light sources for dilated eyes. There's the blue, which is supposed to be good for fluorescent. There's this one, which is good for discos. There's this one, which is good for deer hunting. We use for lots of different things that we don't really ever use. So then there's a green light, is for good for Christmas. And then you also have a dimmer on here in the front as well, which gets yours pretty dim. So, okay, so the first thing that you do when you're doing the fundoscopic examination is you're looking for amblyopia or strabismus. You stand back pretty far and you put your your otoscope on the largest setting. Have your patient look at my nose, and then you shine a light to where it's covering both eyes at the same time. Now you see in Mackenzie's pupils, there's a bright white light, and it's approximately the same spot in both of her pupils. And that's what you're looking for. If it's displaced any or not visible, then there could be some amblyopia. So that's the very first thing you do, very quick, just to make sure it's in the right area. The next thing that you do is you look for a red reflex, and you're still standing about a foot or two away. You put the otoscope up to your eye, and you look in your patient's pupils, and look to see that it reflects back a reddish or a pinkish color. What you're doing is looking essentially at the retina and making sure there's nothing in between you and the retina, like a big cataract that would look white. And so that's very quick, where you just put the scope up, look, and you see red.
Infants, a retinoblastoma, which would look black.
So that's the red reflex. Next, you do the actual fundoscopic exam. Remember that you want to adjust this to your vision. So you'll look pretty close at your hand, and you will keep dialing. I'm usually a red one. You'll keep dialing until you can see the lines on your hand very clearly. So that's good for me. Now, it's adjusted for me, but now remember, my patient's wearing glasses, so she either probably has a myopia or a hyperopia, and so depending on what her eyeball looks like, once I'm starting in here to look, if it's shortened or elongated, I might have to adjust my dial because it's adjusted to me, but it's not adjusted to her. So, and your eyes are fairly dilated now, so that'll probably be a good exam. When you do an eye exam, remember, right eye to right eye, and then left eye to left eye. I'm right eye dominant. It's really hard for me to adjust to doing the left eye. Textbook says that we're supposed to do this with both eyes open. I have trouble doing that, so do you?
Particularly if you are strongly one eye dominant, you may have to close the dominant eye or cover it. You know, you're better off if you can figure out a way to cover it, but that might take a third hand, which a few of us have.
So when I work in an ophthalmology clinic, so I asked Dr. French, one of the docs that I work with, to run over an eye exam for me just to see, and when I did it, he goes, no, he goes, you're not nearly close enough. He goes, you really have to get uncomfortably in their face, like this close, which is why you offset so that you're not bumping noses with your patient. But you start off peripherally, and you really use your finger so you don't actually bump your patient's face. Get that close in there to see vessels, okay? And then you take your time. Remember, there's 4 quadrants in the eye. So you look up, you use the pupil as a fulcrum, and you look down, lateral, superior, and you look at all 4 quadrants. Now, you have your patient look straight forward, but your patient's going to blink, and they may look in other places, and if that's true, then you lose your window, you lose your pupil. Locate it again, back up, locate it again, and go back in there if you need to, because that's a common problem. What you do after you examine all 4 quadrants, you find a random vessel. And then, if need, you adjust your aperture up or down until the vessel is clear. To your vision, and then you slowly follow that one vessel back. It'll get larger, 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 until you see the disc and the cup. You remember the disc is the area where what enters the retina? Optic nerve, and some vessels. It's the physiologic blind spot for your patient because of this. Think of the cup and the disc like a donut and a donut hole. the cup being the donut hole, the disc being the donut, you look at the ratio. It should be, the cup should be less than half the diameter of the disc. And then lateral to that, you should see something that looks a little different, a pinpoint area that's the macula and the fovea, which is the area of highest concentration of cones in your patient's area of best visual acuity. And you can observe that. You're also looking around for different signs of hypertensive retinopathy, diabetic retinopathy we talked about, like flame hemorrhages and within the eye. And the other things are a little more difficult to see in a non-dilated eye, like AV nicking and silver wiring.
And there's one thing I wanted to demonstrate. Sometimes, especially for the vertically challenged people, okay, your patient's up here somewhere, you're down here somewhere. And one way to adjust for that, you're always going to get a better look if your eyes are at the same level, because really, if you think about it, that optic disc is in the equator. I mean, it's straight ahead if your eyes are at the same level. So you basically will take, here I'm being short, I'm going to take Mackenzie and just say lean down and just look straight over there, and then I'm going to come in and look and have our eyes at the same level. It's just a little trick. You don't feel weird. I mean, you're getting close enough anyway. Say, I'm going to put my hand on your shoulder. Is that okay? And I'm bringing you to my level. And then when you get in, you're going to be this close. Seriously. Now, there are a few people who are so, like, there was somebody this morning who has very poor vision in her left eye. So she can't really use her left eye. She has to use her right eye. So that's fine right to right. But when you get right to left, it's a little awkward. So what you do then is you adjust by something like this, by turning your head so that you're not coming in nose to nose. Thank you.
Then the medical board gets called. It's so uncomfortable for everybody. Okay, so that is it. Why don't you guys go and practice yourselves? Look at more than one eye.